though. But let's start. So my name is Marvin. If you don't know who I am, I do work for the ambulance service of New South Wales Ambulance, and I'm also online known as the Growth Paramedic. I'm just someone who enjoys sharing knowledge and building up everyone so, they can provide better care to patients and feel more comfortable once they go on road as clinicians. So a little bit about me. I've been in the service now. This is my fifth year. I've recently completed my master's degree. And I think my goals for the next couple of years is just slowly build up my portfolio of education activities and build a database for people online to reference in terms of studying. And if they don't know what to study, they can come to me, and they can look at the resources that I provide. But yeah, a big part of my passion in this field is to share my knowledge and is to continue to learn and grow as a clinician. One of the things you will learn if you're not on road yet is every job's different. You will go to patients with the same presentation, but they will present very differently. So your history taking is a big part of influencing your decision-making skills when you come to those patients. The objectives of this session, and it's meant to be just kind of a relaxed session. If you have questions or you want to, give a go and an answer, absolutely feel free. But there's three kind of things I want to kind of look at in this hour. It's mainly the principles, the approaches, and some acronyms that you can start to think about and start to memorize and recite to enhance your history taking skills. One thing I do emphasize with acronyms is you shouldn't have them as a concrete, I must use it from A to B or A to Z. It's more of it's supposed to enhance your history taking by taking bits when you need to during your history taking with a patient. This whole thing isn't meant to kind of show you exactly every question you need to ask, because if you look at any textbook, there's probably 1,000 questions you can ask a patient. The main things I want to show you is what are the key things you need to ask, and some, I would say, some diagrams or pathways you can go once you've identified what a problem is and what kind of processes in the history taking you should undertake to get you the best outcome for that patient. But really quickly, what is history taking? There are kind of three principles when we come to the goals of history taking. The first one is obviously you want to get an accurate medical background of the patient, because people don't call 000 for nothing, hopefully. They do sometimes, so maybe that's a bit incorrect, but you are ideally trying to figure out what is going on either medically or trauma, and the causes of the signs and symptoms that they're presenting with. In addition to that, you are building uh, personality, culture, and belief. So you're building a picture of. Sorry, someone just sent me a message. You're building a picture of the patient background. So the entire time you're actually doing history taking, it's not just the questions you're asking. It's also looking at the patient's background, how they're presenting, where they're living at, the environment around them. All that is part of your history taking process. It's not just the words you say, it's the entire environment around you that you're asking those questions in. Because you will find that you go into people's homes, and little details will pop up that will trigger certain questions that you may ask later on during your history taking. You might walk past as you're entering the door a whole packet of used antidepressants, and you're going to someone who's feeling dizzy, who's potentially presenting with mental health. That environmental factor will probably trigger a question later on looking at the medications of that patient and whether or not they're compliant or they've taken a large amount today, in relation to their presentation. And also building and creating trust with patients. History taking is probably a very integral part of report building. I know we say using people's names is really important, but the questions we ask patients and how we ask them really creates a sense of professionalism with us as paramedics. When we ask the right questions and we feel comfortable and confident asking those questions, it instills in many patients the belief that we know what we're saying, we know what we're doing. If we start rambling on and we start doing kind of half effort questions in attempt to kind of fill the awkward space of silence that may happen in a scene, it's very easy for patients to suddenly think, oh, what's going on? well, why do I even bother trying to? I'm gonna tell you to leave now. So making your questions as efficient and as effective as you can really builds that trust with patients. And continuing on to its importance, paramedicine is an evolving field. I think 2018 is when we got registered as a healthcare profession. So before then, you didn't need a degree. Now you do need a degree. And the reason why I say it's an evolving field and why that's relevant to history taking is because a lot of patients these days, especially in my experience now, I probably say a third of them don't go to hospital. And a lot of that's to do with our assessment of the patient, our history taking. A lot of patients now, and with the backing of our services, we can refer them on. We can get referral pathways activated. And a big part of determining whether we refer someone on outside of the hospital space or we take them to hospital is the information we get from our history taking. If we don't know what's going on, if we don't know what the main problems are, we can't make a very good decision in terms of clinical outcomes and what's best for the patient. And we can't make that evidence-based decision. We need to be strong and we need to be sound clinicians. And again, going back to the first point, we do that by getting all the information we need from these patients and not missing something during that whole process. And can't say it enough, history taking can determine the outcome of a patient in our care. We are often, in a lot of patients, the first point of contact. So some patients may have a big fear of the healthcare system, so they may not call anyone, or their culture dictates that they don't seek medical help. So when we are the first ones on scene and they haven't been seen by a professional in the healthcare realm, we have a big impact in terms of guiding them towards the help that they actually need. And this is a really good quote, well, not quote, but really good kind of understanding of the whole history process in terms of everything we do, assessing a patient by listening to a medical history and examining the body systems to formulate. And we always say provisional diagnosis is a timeless skill. We must work on it every time we talk to a patient, every time we ask questions. Even in your first year, if you haven't even started on road, write down the questions that you are actually asking patients and think about, is this the right question to ask? And maybe even evaluate how effective those questions were. Did you get the answer you were looking for, or could you pick a better question? Because you will find as you go to patients and patients and patients, you are asking very similar questions, especially those first 5 to 6 questions. They tend to be the same questions all the time. So learning which questions to ask and going straight to those questions when you need to, especially in those critical patients, will mean the difference between, saving someone's life and potentially someone dying on scene. And a really good example, and this is now moving on to the actual process of history taking, is you need to get this into your mind. History taking begins the moment it drops on the dashboard on your MDT. So if you are on road, if you get a call, let's just say you're at station and dispatch calls you and says, "Hey, we got a job for you." History taking actually starts at that point. It doesn't actually start when you get on scene. You need to be thinking about the questions you're going to ask the patient before you get there. Because if you're trying to work that out whilst you're doing other assessments, it's too much cognitive overload. You will find with your clinicians on scene that they will have a set of questions they're going to ask straight from the bat, and the way they're going to build those type of questions is by looking at all the information that they've received before they even got on scene. So have a little scenario here. I've made this up. You guys are more than welcome to chip in, but have a quick read of the MDT. So this is a completely fictional scenario, but what kind of things can you see in the details there that might have you thinking about certain demographics and certain potential things you want to explore when you get to that patient? Um, I'm gonna leave that to the board. If no one wants to say anything, then that's fine. I'll just continue on. But is there anything here that kind of triggers your senses? Oh, make sure I haven't muted everyone. Oh, sorry. It's okay. There's no wrong answers.
Well,
Uh,
I guess age is a big one.
yeah, yeah, absolutely. age is definitely 54 years of age, so he's in that older demographic. So we want to be thinking, what risk factors does he have there? Potentially, he's on medications, high blood pressure medications. We're thinking potentially cholesterol issues, diabetes. The older the age with chest pain, that was a really good one. Anyone else? I'm just going to move on to the next one. But these are the kind of things that if I looked at this MDT, I'm already thinking about these kind of aspects of it and what questions I can start thinking about in my head. So I know it's a 1C. If you're not in New South Wales, it's kind of a I think it's a category 2 now. So it's a lights and sirens response. So it's an urgent call out. We have a male, female versus male. So that's something to be mindful of. 54 years of age. We know this patient's in the older demographic. Obviously not greater than 65, but the risk factors are there as you get older. Things like atherosclerosis, plaque buildup tends to get worse over the longer you live, really, as plaque builds up in those vessels. So again, that's a risk factor. Chief complaint, huge one, chest pain. We already have something we can start digging into when we get to that patient. This patient has chest pain, so we want to look at what questions can we ask around chest pain, and there's an acronym that we're going to look at later. But knowing what your chief complaint is a big part of your history taking, and it really helps build a systematic approach when you have something to latch on. Some other things to think about is clammy. Why is the patient clammy? Where are they? I mean, it's a different kind of situation if he's gotten out of the shower and he's clammy, or if he's on his bed and he's clammy. He's unable to get out of bed. Why is that? Could be pain, could be something else. He could be having faints if he's trying to get up from there. He could be having a heart attack. So all these things are running through my mind. Another one often happens is either they've had aspirin or they don't have aspirin available. Why is that the case? That's often a big clue with your history taking. If you find that they say that they've taken aspirin, then you already know that they have some sort of cardiovascular history. If they have some, or stroke history, if they have aspirin already on scene, and ETA by the caller. So all these things, if the caller is asking for an ETA, generally means that, you know, the patient's getting worse, the family on scene is getting stressed, and they want someone there they want a healthcare professional to take control of the scene, which is the case here. So any questions around that? Let's go to this one. So completely different scenario, but now you're going to this one on the MTT. What kind of things would you immediately think about if you saw this on the MDT? Remember, there's no wrong answers. Anyway, these are the kind of things I'd be thinking about. It's a 1A, so it's the highest response category for New South Wales ambulance, and it's a 27-year-old male, so he's young, he's full of life, those kind of things. Unresponsive, so history taking is going to be very challenging with this patient. They're not going to give you anything if you ask them, hey, what are your allergies? There's no way this patient is going to potentially say anything. Agonal breathing, peri-arrest, but we have bystanders on scene. So if I saw that on the MDT and I saw there were bystanders and they given a detailed description of what's happened, they're going to be the people I want to go to for my history taking. They're going to be the ones that I want to ask questions about. A really good ones that I've been thinking about for bystanders is, did you see what happened? What happened? And all those kind of questions start moving across as you go down that history taking pathway. But also be saying to the bystanders, do you have the contact number of a family member or the next of kin or emergency contact? Because if the patient's unconscious, emergency contact is a good one to ask questions because they will have details about the patient's history. Generally, people who are emergency contacts are the ones that have the most details on that patient. So those are things I'll be thinking of. Again, bleeding, uncontrolled head strike, TBI, spinal, major trauma. We know that additional resources are en route. So our history taking can dictate whether or not we need to activate further resources. So if we need to activate helicopter retrieval services. But I always say with all these jobs and all these scenes here is context plays a really big role in our history taking. Avoid tunnel vision. Be fluid in your history taking and adapt and adjust to the situation you're placed in. It's very easy, again, for the first patient to come in thinking it's going to be a heart attack, it's going to be a heart attack, but you've missed a potential aortic aneurysm or you miss something else by funneling your vision to one particular provisional diagnosis. You need to be mindful of bias and you need to be mindful of the different types of cognitive bias like selective bias where you're kind of picking different things to, I guess, enforce what you think is right. When you're doing history taking, be as objective as you can. With that, don't try and push patients towards a certain diagnosis or don't try and say, and a really good example of that is pain. If you're asking a patient, especially around chest pain, what the type of pain is and how it feels, one of the very easy ways to get tunnel vision is to start asking patients, do you have a crushing pain? Do you have the problem with asking very specific history taking questions like that is patients may not have the medical knowledge to really understand what that means. And they may very well say, oh, yeah, I think I actually have that. But if you actually allow them to explain what they're feeling, and a really good way to say that is, can you please describe what that pain feels like, or can you give me a description of that pain? Allowing the patient to describe for themselves avoids that tunnel vision entirely because now they're saying it from how they feel from within. So if they start, oh, actually, that pain's more of a like a tearing pain that kind of goes to the back. It's not really a heavy crushing pain now that you mention it. It's more of a that's going to dictate the next direction of your history taking. So just be mindful of going in there with too much commitment to one thing. Take everything into context. And I always say history taking is a means to an end. It's not really a time to do small talk or like asking about the weather. You want to get as many answers with the least amount of questions that you have to ask for that patient. And in the pre-hospital setting, realistically speaking, you're probably with a patient, depending on if you're going to refer a pathway for a couple hours or maybe 30 minutes, 40 minutes. In the hospital setting with doctors, they're with patients for hours, or they can be with patients for a far greater amount of time. So we really don't need to go super in detail with the type, for example, with the texture of their bowel movements. We don't necessarily need to go down that depth unless it's very relevant to the nature of the presentation, if it's a bowel related presentation. But not every patient requires the most thorough questioning. It's mainly the most relevant questions. And a good way to think about it is history taken when done well has these kind of effects. So it firstly influences a positive outcome for these patients. It yields a variety of provisional diagnoses. So you can, again, with chest pain, you can think this could be a PE, this could be aortic aneurysm, this could be pericarditis, it could be a heart attack, it could be a range of things. So it allows you to think about potential things, and then you can then think, well, okay, what is the worst one that of the three that I've listed, what is the worst one we need to rule out or rule in? And we're going to explore that next. Providing the most answers with the least amount of questions is the ideal, and the way we do that is using open-ended questions, allowing patients to actually talk rather than you talk for the patient. If you guys are aware, there's kind of two ways we ask questions. One is mainly open-ended questions, and closed-ended questions. A really good way to use open-ended is, can you tell me how you're feeling today, or can you tell me what's been going on today? A closed-ended question will be is, do you have sharp pain? So sharp pain is either yes or no question, whilst the first one is the patient needs to kind of talk to you and respond in more than just a yes or no answer. And the good thing about that is if you built that rapport with the patient, they're going to give you a massive treasure trove of a response that allows you to kind of then segue to different other questions. Because most of the time, and you'd hope so, when you ask a question, a patient will answer, and by answering, it's going to open up another full set of questions. It's going to give you more questions to ask afterwards. But again, good history taking builds rapport and confidence and care. And in the long term, if you do go to hospital, it allows a good transition to the hospital environment. When you have a really good understanding of what's going on with the patient and what you think is going on with the patient, when you get to hospital and when you get to handover with the RN at triage or at bedside, you already know what's going on. You're not trying to pick that out whilst you're with the patient. You have those details there, and that can be transitioned so the RN on scene or the doctor, if it's in resus or something like that, can continue that high level of care once you've leave that hospital setting. So these are a couple of the acronyms that I have found I tend to use more often or not within the pre-hospital setting. I would dare say the last two are probably the least I use, but the first four are probably the most common acronyms I have used in the last 5 years or so. I will say in saying that, it's very easy to look up these acronyms. I think the next ones kind of go through it, but I recommend just write them down and just look up the acronyms themselves, and think about how you would ask those questions. But I kind of generalize how these acronyms work. So ample, it's a very generic set of questions, but it's what I would call the need to know. So generally speaking, with most patients, you will eventually do an ample, not necessarily in that order, but you want to eventually know what were the events leading up to the presentation. What did they last eat, particularly if you think they may need to go to surgery or they're diabetic or they've had a syncope, uh, previous medical history, medications, allergies. These are just your stock standard gold standard questions that need to be explored with any patient. Your OPQRST is my favorite when it comes to pain related presentations. Any patient that has chest pain, abdominal pain, a headache, even anything that ticks the pain box, I will be doing a OPQRS style history taking immediately with that patient to establish any patterns that correlate to a potentially life-threatening presentation. An example of OPQRST is abdominal aortic aneurysm or ruptured AAA, shearing pain in the umbilical region, radiating to the back, 10 out of 10 pain, happened 10 minutes ago. That's ticking the boxes now for this patient's about to die on me. Champs, I like that as a generalized. It's similar to ample, but champs is kind of really the main one that I would say most clinicians use subconsciously within the pre-hospital field. And champs is probably the one you want to really know down pat. It's your chief complaint, history of chief complaint. Those two are kind of the main things you always do with patients. And Socrates is your, how I've come to find it, everything that is in pain. So if someone's short of breath, you're more likely or not going to do a Socrates acronym style history taking. If someone's nauseous or they're having diarrhea, you're probably going to do a Socrates kind of history taking again with those patients. It doesn't fall exactly into a pain related, but it's enough that you want to explore everything around that. So, and the last two I've added just because they're similar, but they add to exploring symptoms because a fair amount of our job is exploring people's pain, people's symptoms. I've just been lethargic for the last 10 days, or I've had a headache for 2 days, or those last three acronyms are good for building up I guess, your methods for exploring those symptoms. And moving on to the next slide, because it is important now that I've showed you those acronyms, is that they are only supposed to be guides and adjuncts to patient care. If it's not 100% relevant to the patient at that time, don't start going down the acronym pathway from A to Z. And I love this example. I've just used an AI generated, but basically, if someone's hemorrhaging out, you don't want to start off with the ample and say, "Do you have any allergies? What's your medications?" Because it is a slippery slope down the wrong hole, and you will most likely have a bad outcome. So use critical and sound reasoning and decision making skills when asking questions. How I like to imagine using the acronyms is picking out certain parts of it when it's appropriate or when it's needed. And if you're stuck with a patient, you already asked a couple questions, and now you're sitting there, you're kind of twiddling your thumbs and thinking, what am I going to ask next? look back at the acronym and see if you've missed any of those parts. And if you have, now it's the time to ask those questions. And this is an example that I really do like, and it's just one of many different types that you will potentially go to. But this is how I kind of picture and how it ended up me most times with patients, how history taken has gone. So you have your presenting complaint, which is just your gold standard in terms of you need to know potentially what's going on with this patient. Chest pain, generally unwell. Where this can get a bit iffy is if the patient doesn't tell you what's going on, then you need to make that clinical decision making skill of determining what's going on. So if they don't tell you, they don't know what's going on, you need to make an educated guess to from your history taking, from your vital signs, from everything, from context. And so, example for chest pain, again, patient has pain. I'm going to do a PQRST. I'm also going to do elements of ample as well to get a history of their medications, previous medical history. Whilst I'm doing that, my partner's getting a vital sign survey. We'll chuck on a 12 lead, um, and we'll do a focus system review. That's the next stage to your first part. Is every patient generally should have a system review. Now, we have all our different systems. You don't need to do all of them if it's not needed. But in this case, for chest pain, the focus system review would be cardiovascular and respiratory because the patient has chest pain. We know in that area they have lungs and they got the heart. So we want to figure out could this be related to the heart or could this be related to respiratory or could it be both? So we'll be going down the focus system review and doing history taking on the respiratory and cardiovascular system. Um, and then from all of that, from all of our history taking, from all our vital signs and comprehensive patient assessment, we will end up making a decision on whether or not this patient needs to go to the cath lab, STEMI, for example, or they can go straight to ED, or they can go to the local GP. But rule of thumb, if they got chest pain, they need a blood test, so they're going to hospital. The more, the more tricky ones that you deal with is your generally unwell patients. So the ones that you come in and you really don't know what's going on. They just haven't been well for the last 2 months. They're getting lethargic, fatigued. So that's probably when you want to start going down the Socrates, so figuring out, okay, what are the exacerbating factors? What are the signs and symptoms? What's everything wrong? Do your full vital signs 12 lead, and in these cases you do a full system review. So you do the cardiovascular, you do the respiratory, you do the gastrointestinal, you do the skin, you do everything. This is the kind of patient where you'd probably be on scene for easily an hour to 2 hours, and that's fine. Because if you find that this patient can be referred on and they don't need to go to hospital, they don't need to go to hospital. But this is just an example of that. And to add on to that, again, mental health. There's so many different presentations you can go to, and history taking has to be contextualized to the patient. So how you question one set of people is going to be completely different to the next set of people. But where kind of all comes together is your first couple of questions. And how I say that is your chief complaint and your history of chief complaint. So you'd say, what's going on today? And if they tell you what's going on today, that's your chief complaint. Now you want to know the history of what's going on today. For mental health, this is kind of example that you'd go through, but in New South Wales Ambulance, we have these acronyms called state, beat, and threat, depending on how they're presenting. If they're suicidal, depressed, and they've got a mental health history, we're going to do all three. And then we're going to do allergies, medications, events leading up. So you can see how different parts of the acronym are getting used depending on what we need at the time. We're not just going from A, M, P, L, E, where we may start with the first CH of champs, do something else, and then we're going to pull things from allergies, pull things from medications and events leading up to it. Hopefully that makes sense with you guys. And then again, shortness of breath is another one. So similar thing to chief complaint. Why are we here today, or why has the ambulance been called? That's our C for champs. The history of the chief complaint. So, how long has this been going on for? And you're kind of now using that Socrates pathway when you're asking about that history of chief complaint. So, you know, when did this start? How long has it been going for? What makes it? Sorry? Oh, does someone have a question? No? Okay. Well, I'll continue on. If you do have a question, please feel free to ask because again, if you have any questions, this is probably a great learning opportunity for everyone listening. But in this case, for shortness of breath, again, once you've done your first chief complaint, history of chief complaint, and your Socrates, very common, you then do your system review. So this patient, again, where is it complaint? It's in the chest area, so that's your respiratory and cardiovascular. So I'm going to do a focus review on those areas, and I'm going to ask questions relating to the respiratory and cardiovascular systems. You can find a whole range of those different specific questions on respiratory and cardiovascular online or in any textbook. Just look them up. I would always recommend, if you have time, look through all the systems and have, or at least write down 10 questions relating to those systems that you can use when you need to. But with any history taking, there are pitfalls in it. And I did mention it earlier, but sometimes we do fall into the trap of thinking that there must be a chief complaint and we must interrogate. There can be times where you just have no idea what's going on. And it's very easy to do. Some patients, especially if they have disabilities or they can't really, if their English is a second language, they can't really give you the information you need. You may be in a situation where no matter what you ask, you're kind of ending up in a circle in a sense. There's no end point to your history taking. And that can happen, and don't feel flustered around it. I always say if you're stuck in that, kind of go back to the beginning. And a really good way that I like to kind of try and figure out potentially what the main reason we're there today. And if that is the case where I can't figure it out because the patient isn't telling me, I may go back to the MDT notes and then kind of clarify with the patient. So look, I understand all these things that you're going through, and I can see that you're this and this and this. It was mentioned in the MTT notes that you had this. Uh, and can you tell me a bit more about that? Oh yeah, yeah, yeah. Actually, yeah, that's why I called because, and then you can kind of connect the piece and oh, okay, so that's actually why we're here today. But you really ideally want to build the main reason there because no one calls an ambulance for nothing. You should try and get that into your heads because when you go to triage, you can't really just say, I don't know what's going on. You want to be a healthcare professional. You want to have some sort of clinical judgment that you've made from all your history taking, all your patient assessment, and you've put it all together and you've made an educated guess then of what you think's going on. So the acopic, the family isn't managing the patient's needs very well. If it's a disability at home or it's a group home or something like that, you can say no, there was raised concerns of lack of care or even like things like child abuse, or you think that the patient isn't getting their needs met. That's as simple as that. And I think I use an example down here is consider a case of a female with ongoing nausea and vomiting, worsening fatigue and lethargy, they're becoming malaise and reduced hunger. And I do remember a couple of years ago, there was a female who had something similar to this, or where she had, I think, 4 to 5 months of just ongoing reduced appetite, unexplained weight loss, nausea, vomiting, history of really aggressive smoking, and a history of cancer in the family. Um, and you connect the dots, you're kind of thinking, this may be related to respiratory. And as I did a bit more history, we were able to then figure out that she was coughing up a lot of hemoptysis, a lot of blood was coming out of her lungs. And from there, you can make that educated guess. She didn't want to tell me anything, but you can make that educated guess that this is potentially a serious condition in their lungs. It could be a PE or it could even be lung cancer. So you might not necessarily say that to the patient, but you definitely want to relay those concerns from your history taking to the next group of people that take over care. So your RN or your doctor at the hospital. I do like this photo as well. History taking is an interrogation. You will find some people can't help it, especially for certain presentations like alcohol or drugs, that they will just slam on questions, expecting get certain answers they want. Uh, this is one of the quickest ways to get an aggressive patient. History taking should always be, and I call it the eight golden nuggets, should always be via a therapeutic communication style. You want to be very mindful of how you talk to patients. You are professionals, you're getting paid as professionals. People look at you as one of the most trusted professions. So you need to keep your anger, you need to keep your annoyance, I guess, in check. You need to show empathy, regardless of the patient. You really need to work on being able to maintain a calm, relaxed composure when you're doing history taking. Don't sound irritated, don't sound annoyed, because patients, they're already in a heightened state. If they've called you for something, chances are there's a lot of adrenaline rushing around. They will pick up every subtle body language and cue that you give them, and they will feel that 100%. So they see you twitching, or they see you kind of looking very annoyed that you're there, they're going to take that as an affront, and they're going to think, great, this patient really doesn't care about me, and they'll shut down. And I can't emphasize this enough. This is really important with mental health patients. There's been some of the most challenging patients with history taking, and it can take hours to build that rapport, and it can take just 2 seconds to shut them down completely. So just be very mindful of how you communicate when you're doing history taking. So body language, very obvious one. Try not to cross your arms. Try to have an open body language. Try to maintain, especially if they're shorter or they're younger or the kids, try to maintain eye level contact and using a tone that isn't judgmental. It's hard to enact that now, but I'm sure everyone's had an experience where people have asked questions sarcastically, or they've asked things in a way that sounded offensive. It's very easy to do that, especially if you're tired at 3 a.m. in the morning and you want to go home. It's very easy to make your questioning sound um, judgmental. So just be mindful and really come into every case with that knowledge that, the way you say things does come off very easily to your patients. And I'll probably go to this video. It only goes for a minute, but I did kind of clip this video from Ambulance Victoria. It was kind of a good example of the CHAMP acronym. This is a shortness of breath patient. So, and I always recommend if you can watch some of these ambulance shows. I generally try not to watch it because I'm already working. It's kind of like looking at your workplace. But if you are just getting started in this area of work, or not really haven't been in the ambulance for too long, these are the great like resources to use, because these are real people going to real cases, and how they're talking is as if they're actually with the patient without the camera. But let me know if you can't hear what they're saying. That's gonna be a real guess.
What's my process? We're going to an 83-year-old female. She feels like her heart is pulling and she feels quite short of breath. She is clammy. She's never had a heart attack before. For luck. It sounds like the patient is critically unwell, and we want to get there and start managing her and get her off to hospital quickly.
Okay. What number, Emelina?
3.
Pulling heart, shortness of breath, and clamminess. These are three very alarming symptoms. This lady could be having a cardiac event. So Em and I are really concerned that this patient will be quite sick when we arrive.
What was your name? Rudy. So tell me what's happening today.
So just stopping there, could you guys hear that? Yes, no? Hopefully.
Yeah, we could.
Oh, wonderful. So just going off, thank you very much. Just going off that, so they already kind of described the MDT notes. You're going to shortness of breath. The first question you should ask, and technically it's not really part of your history taking, but it's also really important, is asking patients' names. So the first thing she said is, "What's your name?" And you introduce your names as well, because if you can refer to your patients via their names, it builds that rapport from the very beginning. And I always recommend don't ever refer to your patients as you or he, them or her. Just go with how they want to be addressed. And when you ask questions, for example, if I'm with a patient called Sarah, if I'm going to ask her a question, I want to say, Sarah, can you tell me how you're feeling? Um, don't try and use alienating words is how I'll approach it. But after that question, she then said to the patient, "What's been going on today?" She used the question to build up the chief complaint. We already know, well, she already knew from the MDT that she potentially is going to have some sort of respiratory cardiac related symptom. But by asking that question, you both clarify with the patient why they called the ambulance, because sometimes they may change their story when you get on scene. But being able to clarify that from the get-go and being able to narrow down what the chief complaint is allows you to suddenly, okay, cool, we've got shortness of breath. What acronym can we potentially use? Socrates. What things do we need to do? We need to do a full vital signs survey. We need to listen to the lungs. We need to do a 12 lead. We now need to eventually get down to a focused system review of the cardiovascular and respiratory system by asking questions relevant to those areas. So by getting your chief complaint identified, you can go down the route of that history taking that's efficient, that's effective, and gets you the right outcome for that patient. So we know this patient's short of breath.
Okay.
He just come out of hospital a week ago.
So this is another example here of allowing patients to explain or give you answers. So she only asked this patient one question, but the patient has decided during that answer to actually tell them that she was actually in hospital a week ago for a similar presentation. That's a lot of red flags now. You now have 10 questions you need to ask the patient, but it goes to show that you want to allow patients to give you the answers that you're looking for, and you want to make sure that if you are going to give patients closed-ended questions, that it's important closed-ended questions. So if you're going to have to say yes or no, make sure that you leave it to the minimum. Adding on to that, look at the background of this patient. You want to see all the environmental factors. You can see there's use of food here. So social living, does she cook? Does she clean? Her activities. So when I was looking at this video, I'm kind of looking at the entire environment around it and seeing things that might potentially lead me down to some further history taking later on with this patient. But let's continue on.
Okay, what was that for?
Same.
I'm just going to check your heart. She was in hospital last week. And at that age, if you're experiencing a lot of cardiac symptoms, it would be very daunting because you'd think, this is it for me. This could be my last day here.
Is there any chest pain with the shortness of breath?
Pulling
Can you point to where the pulling feels?
round around here.
Immediately, I'm worried that this patient could be having a heart attack or suffering acute pulmonary edema, fluid on the lungs. Both are incredibly life-threatening. Have you ever had that before?
Yeah, but not as bad.
Not as bad. All right, love, just take nice, easy breaths for me and just sit forward.
83-year-old Ruby has chest pains and shortness of breath.
Nice, easy breaths, Ruby.
As Emily listens to Ruby's chest, Steve is on the phone with her daughter, trying to find out more information about why her mum was taken to hospital only a week ago.
Okay. So again, this is a bit more good decision-making skills from the crew on scene. But we already established there's two complaints here. The shortness of breath and chest pain. Those are two symptoms in themselves. So this patient will probably need, you want to be thinking Socrates, PQRST, OPQRST, and that red flag of the previous hospital admission a week ago. You want to be searching for everything you can about why was she in hospital, what were their findings, do they have a discharge paper? And I always say, if you can find a discharge paper, regardless if it's a couple years old, it tends to be a gold mine in terms of the medical history of these patients, and also just grabbing all their details, their first name, their last name, and their date of birth. Because I can tell you right now, I'm a terrible spelling bee champion. If people give me their last names, I'll 100% forget it, and I'll 100% forget how to spell those kind of things. So discharge papers are really good. You'll find a lot of elderly patients will have discharge papers or medical papers lying around. And if you can grab them, that's perfect, because if you can take it to the same hospital, if you are going to the same hospital, a lot of these papers have what we call MRN numbers, so numbers that correlate to the patient, and basically it expedites their admission to the hospital if they already have that number. But with this guy here, he, similar to the emergency point of care, he's contacted the daughter because obviously the patient's short of breath, they got chest pain. Asking the patient 100,000 questions around what's going on can be very challenging, especially if they can't actually catch their breath. So utilizing other people like bystanders, calling the daughter to get more information can help build that picture simultaneously whilst you're listening to the lungs. So you will find in these cases you're working as a team to get history. It's not just one person, it could be both of you. So you may find that you're going to a mental health patient your partner may be asking questions to the patient, but you may be going to the family on the other room asking questions around the patient's background. So just be mindful of the fact that you as a team will be doing that together.
So she does have CCF. Okay.
CCF, or congestive heart failure, is a condition in which the heart muscle is unable to pump enough blood to the body.
So she's got fine crackles to left base. The good news is the ECG shows that Ruby isn't having a major heart attack. You feel short of breath with that, but she's got fluid backing up in her lungs.
You had fluid on your ankles last time, and you've got a little bit again. So your heart's backlogging. Too much fluid. When the heart is starting to fail and it can't pump the blood to the body properly, it starts to backlog into the lungs, which cause an accumulation of fluid. Essentially, she's drowning from the inside out.
This was just a really good example in terms of he's used that history of the fluid buildup in the legs being related to the last time she was in hospital for heart failure, and everything is leading up to, again, with the respiratory assessment of listening to the lungs and hearing the crackles in the lungs and the fact that she's short of breath, and also ruling out potentially an obvious heart attack via STEMI on the ECG. All that coming together has built that history taking picture of this patient probably has a representation or worsening congestive heart failure. But they use what's called the chain reaction method. So very simply, use of line of questions that focuses on a single issue, and the answer will formulate a question that adds to additional information. So you found that the first question or second question that she talked about shortness of breath, found that there was about 10 different questions that you could then focus on around that issue, especially around the previous admission to hospital. And you will, when you go on road, you'll find that a lot of people end up going through this method of questioning, is that once you ask one question, everything else opens up. And it's all about you using that open-ended style questioning and allowing the patients to essentially consult with you about what they're going through. So I kind of summarized it to like a stepwise approach. So first one is chief complaint. So reason for the call. You really want to establish that first, pinpoint what things you want to start investigating. And it sets the tone for the history taking further on with this patient. So because this patient was short of breath and then talked about chest pain and mentioned that she had been in hospital a week ago, the history taken then focused on around the shortness of breath and chest pain, and also focused on the history of her admission to hospital a week ago with calling the daughter. If a patient or bystanders cannot provide one, again, you would need to make a judgment call from the principal complaint based on your decision-making skills, your reasoning skills, everything that's come together. So the notes on the MDT, your assessments, your findings. But if the patient can't answer, try and get a bystander to give you information if they can. Again, after chief complaint, history of the chief complaint. So this is where it kind of goes down different pathways. So if someone's got a generalized, symptom, you might want to do CHAMPS, you might want to do Socrates, you might want to do old carts. Basically, one of these will help guide you. Again, this isn't a Bible. I wouldn't say you go straight from sight onto. You may want to use different parts of that, depending on the relevance of that patient presentation. But these are the kind of acronyms that I would have at the back of my mind if I'm asking questions, to make sure that I'm asking the right questions and I'm getting the information I need to when I get to the hospital and I have to do a handover. Again, if you are doing a pain assessment, just be very mindful that patients can be very subjective in their pain scale. So you just have to take everything into context. So I would say the guy on the left saying he's got 10 out of 10 chest pain and he's holding his chest and he's clammy, you can probably say, yeah, this guy's actually generally. But if someone's on their phone in the stretcher and they're doing Snapchats and they're smiling, they're laughing, and they're saying the pain's 12 out of 10, and they're asking for morphine or fentanyl or ketamine, you can kind of put everything into context. You know what I mean? So yes, you're getting things from the patient, but you also need to make an educated assessment of the information you've got. Just don't always take everything face value. Put everything into context. The next thing you want to do after your chief complaint is get the rest of the adjunct questions. So your medical history, really important. If you've had it before, you can have it again. An example for the video one is that she's been to hospital for heart failure. Um, chances are you can have that heart failure again, or it can be worse. Your medications can stop working properly. You can be non-compliant. Um, do ask if they have anything, especially if it's relevant to the presentation. So if they got chest pain, you want to be asking medical history around anything cardiovascular. Do you have a history of stents put in, any history of heart attacks? All those kind of things are important to determine the risk factors in play. Allergies, very quick one to ask is what allergies do they have? When did it occur? The type of reactions. Those ones are more relevant if you are giving medication. So if you're going to give aspirin or any medication to treat a patient, they generally become the first kind of question you ask those patients from the get-go. So it's not necessarily one of the last questions you'll ask. You may end up being in a situation you got to ask that question in the first three questions you ask that patient because you're going to give them a medication. But if they're having allergic reaction, again, you want to be exploring that part of the history taking as well. Medications, looking for medication boxes, looking for Webster packs, discharge papers. You want to identify a medication name, talk about when they last took it. Some patients only have medications in the morning or at night. Some patients take it when they need to. And also looking at compliance. If patients aren't taking their medications when they're supposed to, or they're taking too much, or they completely stopped it, you want to be asking questions around, why have you stopped this? What's your reasoning around it? Because chances are, patients may end up giving you all the answers you need, and they may say, "Oh, look, I've stopped taking this medication because I'm getting side effects like a headache, but now my blood pressure is 210 and they're fast positive." So important to always dive deep into medications if they have any. And as well as that, patients are never the best historians when it comes to their medications or their medical history. So patients can say, and it's happened many times where they will deny any medical history, but you look at their medication box and they got cholesterol medications, antidepressants, so if you find any meditations on saying, just explore each one with the patient and figure out why they take it. Even if you know what it is, chances are patients may say things that you might not realize they're taking. They may be taking something thinking it's for something else. And a really good example of that is a patient I went to I think a year ago now, where a mother had given a child um, a 1 gram of paracetamol every 4 hours for a headache, thinking they were helping the patient, but the patient continued to have headaches for the next 2 to 3 days. And the mother was very adamant that, "Oh, I'm taking it every 4 hours. I'm being very good. I even wake up the daughter, to give it, at night at 12 at midnight because of the headaches." But the patient isn't sleeping. The patient isn't is getting disorientated, is getting angry, is getting disturbed. And looking at the medication box, each of those 500 milligrams of paracetamol also had 80 milligrams of caffeine into it. So this patient was getting the equivalent of 2 coffee shots every 4 hours at a very young age. And I think calculating the total amount of caffeine she had in 3 days, it was about 2,000 milligrams of caffeine. So you can imagine how important it is to figure out why patients are getting medications, because it could really end up being the reason why you're there in the first place. That patient's fine, by the way. But continue on. Family history, risk factors, identifying risk factors. Uh, I always say with family history, it's a huge one, especially for genetic factors like heart attacks or like sudden cardiac death. If you know about Brugada syndrome, people kind of downplay genetic factors as, it's a risk factor, but it's not as important. We're very easy and very quick to say, "Oh, you have your mother's eyes, or you have your dad's hair." We should also be thinking you have your mother's cardiovascular history, you have your dad's diabetes, you have your grandfather's seizures. We've got to be very careful that if someone in the family has a condition, that they may potentially have that too, and it could be undiagnosed. A really good example is a history of epilepsy. Someone's been having a seizures, or they've had a crash in a car, and they're woken up and someone saw them doing shaking in the car at the time, and you find out later that the family has a history of epilepsy. You may want to be concerned that this is an onset now of unmanaged seizure activity. Social issue, just after you've done everything else, you want to look at substance use, living situation, employment, mobility, support networks, basically everything else to build the last bit of the puzzle with this patient. And this is more of a if you're going to leave them at home kind of thing, or if they're quite unwell, and you find out they're living by themselves, they're unemployed, they're taking a huge amount of substances, then you probably know that they're not safe to be left at home. So all of these things, when you put it together, creates that massive final decision making of if we're going to take them to hospital or if we're going to refer them on. And I did add at the end here the focus system review. So once you've done these kind of things, I would chuck focus review probably before social history, purely because you'll probably be doing that the moment you find out if they have a system involved. So if they got respiratory, cardiovascular, gastro, you want to start be thinking about, okay, what questions do I need to ask around gastrointestinal system or the respiratory system? Um, but each one, again, you could go through hours looking at each particular system. So I just recommend that you guys look through all the systems and have at least like 8 to 10 questions that you can ask around cardiac, respiratory, gastro, skin, allergies, immunity, all those things. But yeah, that's it, guys. I think we finished on 1 hour on the dot. So how good's that? If you guys do want a recording, just let me know and I'll send that through to you guys. But thanks again for attending. If you want a certificate, just send me an email or message and I will send that through to you guys.
Thanks, Marvin.
Thanks, Marvin.
Yeah, thanks, Mark.
Thank you, Marvin.